Welcome everyone. Today, we are talking about neonatal metabolic physiology. When we look at a newborn, we aren't just looking at a smaller version of a child. This lecture, titled The Fragile Balance of Demand, Reserve, and Maturation, is a visual guide designed to explain exactly why neonates are uniquely vulnerable to rapid metabolic decompensation. We will analyze the overwhelming physiological demands, specifically neurological demand, glucose consumption, and absolute oxygen requirement. And we will contrast those demands against the infant's shockingly limited hepatic reserves, suboptimal glycogen storage, and severely immature enzymatic pathways. Understanding this specific interplay is what separates reactive neonatology from proactive, preventative care. The placental cliff edge. Let us begin at the exact moment of delivery, a phenomenon I like to call the placental cliff edge. If you look at the graph on your screen, the prenatal phase is defined by a perfectly flat, uninterrupted line. Inside the womb, the fetus enjoys a luxurious, continuous intravenous infusion of maternal glucose, nutrients, and minerals via the placenta. Then, birth happens. The umbilical cord is clamped, and the infant is abruptly dropped off the cliff. Instantly, the infant's metabolic system must transition from a constant supply line to an intermittent, volatile enteral feeding schedule. Notice the jagged orange waves representing postnatal life. This highlights a profoundly narrow window of fasting tolerance. Furthermore, look at this critical drop right at birth. The sudden loss of the continuous placental mineral supply triggers an immediate, early risk of hypocalcemia and hypomagnesemia. In the NICU, this is exactly what manifests clinically as jitteriness, hyperreactivity, and in severe cases, neonatal seizures. We must bridge this cliff edge seamlessly. The core clinical equation for neonatal vulnerability. To help simplify our clinical approach, I have broken down neonatal vulnerability into a simple, mathematical triad. Think of this as the core clinical equation for metabolic failure. Block 1 is our baseline, high energy needs. To that, we add Block 2, critically limited reserves. Finally, we factor in Block 3, immature metabolic pathways. When these three blocks combine during periods of neonatal stress or brief fasting, they don't just cause a mild slump. As you can see by this mechanical lever diagram, they create a steep, downward slide that inevitably forces the neonate into rapid decompensation. If you understand this triad, you will never be surprised by how quickly a seemingly stable infant can deteriorate. Pillar 1, a high-performance engine running in the red. Let's dissect Pillar 1 of our equation, demand. I want you to picture the neonate as a high-performance racing engine that is permanently idling in the red zone. Look at the gauge on the left. The neonate possesses an incredibly high basal metabolic rate per kilogram compared to the older child sitting safely in the blue zone. Why? Because the newborn is simultaneously fueling rapid cellular growth, maintaining autonomic thermoregulation, and driving acute organ maturation. Now look at the right gauge. To keep this high metabolic engine running, oxygen consumption per kilogram is peaked at maximum capacity. Because their baseline is already pushed to the limit, neonates have virtually no reserve capacity. When a minor illness, respiratory distress, or cold stress hits, it massively spikes these already peaked baselines, causing hypoxia and metabolic acidosis to develop with terrifying speed. The brain energy paradox. This brings us to the most critical organ-specific challenge in the newborn, the brain energy paradox. Consider the anatomy. A newborn's brain mass accounts for a mere 10 to 15% of its total body weight. Yet, look at the energy consumption scale on the right. That tiny brain consumes a staggering 50 to 60% of the infant's total glucose utilization. To put numbers on this, a term infant requires a continuous glucose infusion rate of 4 to 6 milligrams per kilogram per minute, while a preterm infant requires up to 6 to 8 milligrams per kilogram per minute just to remain neuronormal. Because the brain hoards the lion's share of available fuel, any sudden drop in systemic glucose bypasses typical bodily symptoms and manifests immediately where it hurts most, as seizures, lethargy, and irreversible neurological injury. The neonatal brain does not tolerate energy starvation. Pillar 2, critically limited energy reserves. Now let's look at the other side of the ledger, Pillar 2, reserves. If the neonate's energy demands are massive, their storage tanks are dangerously empty. Look at these three energy batteries. First, glycogen stores. They are incredibly small and rapidly depleted within hours of birth. This is a crucial, daily vulnerability we manage in preterm, small for gestational age, and perinatal hypoxic infants. Second, fat stores. Fat is supposed to be our primary energy buffer between feeds. However, a term infant has limited fat, and a preterm infant possesses near zero adipose reserves. They cannot reliably rely on lipolysis. Third, look at the protein reserve. What little protein they have is entirely dedicated to rapid growth and tissue synthesis. There is no excess muscle mass or protein available to be broken down for fuel. Consequently, short fasting periods immediately exhaust the glycogen tank, trigger severe protein catabolism, and cause profound hypoglycemia. Their starvation tolerance is virtually zero. Pillar 3. Alternative fuel pathways are under construction. When glucose drops in an adult or an older child, the body seamlessly shifts gears to alternative fuels via gluconeogenesis and ketogenesis. In the neonate, however, Pillar 3 reminds us that these backup pathways are still actively under construction. Look at the metabolic fork in the road on your slide. When blood glucose drops, the pathway to gluconeogenesis, synthesizing new glucose from amino acids, lactate, and glycerol, hits a severe, narrow bottleneck due to immature hepatic enzyme capacity. Simultaneously, the pathway to ketogenesis is completely blocked by an administrative road barrier. While ketone production develops slowly after birth, it remains highly inefficient in the early days of life. When primary glucose fails, the neonate lacks the alternative fuel fallbacks that protect older children. They don't have a backup generator, they just crash. Systemic immaturity, hepatic and renal bottlenecks. Let's ground this biochemistry into physical organ systems, focusing on the hepatic and renal bottlenecks. First, look at the hepatic immaturity callout. The neonatal liver is dealing with a triple threat of developmental delays. 1. Poor enzyme capacity limits glycogen regulation, leading to hypoglycemia. 2. Deficits in bilirubin conjugation lead to a buildup of unconjugated bilirubin, causing clinical hyperbilirubinemia. 3. Immature cytochrome P450 pathways delay drug metabolism, compounding the risk of systemic toxicity. Now shift your eyes down to renal immaturity. The newborn kidneys suffer from an immature renal acid excretion capacity and a severely limited systemic bicarbonate buffering capacity. When you combine an immature liver and kidney with a sky-high metabolic rate, any clinical insult, be it sepsis, hypoxia, or shock, instantly spirals into severe, uncompensated metabolic acidosis. The metabolic maturity spectrum, neonate versus older child. To visually solidify this contrast, let's look at this comparison spectrum mapping the neonate against an older child. Notice where the orange sliders sit for the neonate. They are pinned entirely to the far left edge, representing the extreme of vulnerable zone. Metabolic rate and brain energy demand are dangerously high. Fasting tolerance and gluconeogenesis or ketogenesis capacities are critically low. Acidosis risk is pinned to the maximum setting. Now look at the blue sliders of the older child, resting safely in the stable, mature zones with wide physiological buffers. The takeaway here is definitive. The neonatal state is defined by existing at the absolute extreme ends of physiological capability. They operate continuously without a built-in safety margin. The stress cascade. Why minor triggers cause major collapses. Let us look at how this all culminates in real-time clinical practice through the stress cascade. This slide explains why a seemingly minor clinical trigger can cause an absolute systemic collapse in the NICU. Stage 1 is the trigger. This could be something as simple as a single missed or delayed feed, mild hypothermia from a prolonged procedure, a low-grade infection, or mild respiratory distress. In an older child, this trigger is easily absorbed. But in the neonate, look at stage 2. That minor trigger hits our core clinical equation, an engine already running at high demand, a fuel gauge showing limited reserves, and alternative backup pathways that are completely crossed out due to immaturity. Because the system cannot adapt, the cascade flows unimpeded into stage 3, rapid metabolic decompensation. Sepsis, fasting, or cold stress trigger a systemic chain reaction where high demands immediately exhaust limited reserves, the immature metabolic factory fails to recover, and the infant enters multisystem failure. As neonatologists, our job is to anticipate this cascade. We must aggressively manage the thermal environment, protect glucose infusion rates, and intervene at stage 1, because the neonate simply does not possess the structural architecture to save themselves. Building directly upon the concept of a fragile metabolic framework brings us to the ultimate stress test. When we transition an infant from placental nutrition to enteral feeding, we aren't just asking them to digest milk. We are effectively running a massive stress test on their genetic metabolic machinery. Because the neonatal metabolic system operates under such heavy stress immediately after birth, underlying inborn errors of metabolism, IEMs, will unmask themselves and present dramatically within hours. While older children with these genetic defects might present subtly over weeks or months, neonates do not have that luxury. They deteriorate violently. Look at the abstract metabolic map on the left. The orange X marks highlight the three primary areas where pathways break down. 1. Urea cycle disorders, where protein breakdown hits a wall. 2. Organic acidemias, causing toxic organic acid accumulation. 3. Fatty acid oxidation defects, completely disabling the infant's ability to mobilize energy during fasting. When a newborn carries one of these genetic blocks, they hit a physiological dead end. Look at the diagnostic cues box on your right. We must have an incredibly high index of suspicion. If you see unexplained poor feeding, profound lethargy that seems out of proportion, treatment-resistant seizures, severe metabolic acidosis, or skyrocketing hyperammonemia, you are not looking at simple sepsis. You are looking at an unmasked IEM. You must stop protein intake, push high-dose 4-glucose, and order a metabolic screen immediately. Clinical endpoints, the diagnostic warning signs. To wrap up our clinical exploration, let's summarize everything we've discussed into 4 distinct operational quadrants, the diagnostic warning signs. Think of these as the concrete clinical endpoints you will monitor at the bedside every single day in the NICU. Let's go through them systematically. First, glucose disorders. Look at this volatile tracking curve. Neonates face a universal risk of profound hypoglycemia due to their depleted stores. Conversely, remember that our micropreemies and sick preterm infants face a distinct risk of hypoglycemia because their immature livers cannot regulate insulin responses under stress. Second, acid base and nutrition. Look at the pH color spectrum shifting heavily into the red zone. This indicates a rapid progression toward rapid metabolic acidosis, accelerated by protein catabolism where the body strips its own tissues for fuel, culminating in poor growth and failure to thrive. Third, electrolyte instability. As noted during our discussion of the placental cliff edge, look at these cellular channel graphics. The abrupt loss of placental minerals directly creates a high risk for hypocalcemia and hypomagnesemia, which destabilize the neuromuscular threshold. Fourth, IEM presentations. This is our final confirmation pathway. When the metabolic machinery fails, it manifests explicitly as the triad we just highlighted: urea cycle disorders, organic acidemias, or fatty acid oxidation defects. As we close this lecture, always remember the ultimate biological trade-off. The price a neonate pays for supporting rapid cellular growth and massive brain development is profound metabolic fragility. We cannot afford to be reactive. Anticipation, tight environmental control, and the aggressive prevention of metabolic stress are not just clinical goals. They are the foundational cornerstones of modern neonatal care. Thank you so much for your time.